Ultrasonography in the intensive care unit has become a valuable tool for expeditiously, safely, and effectively diagnosing and treating a constellation of conditions commonly encountered in this setting. Over the last decade, ultrasound in trauma patients has become an extension of the physical exam through the application of the F.A.S.T. More recently, ultrasound has spread to the ICU. In the critically ill, a quick survey with the ultrasound probe can provide crucial information regarding volume status, grossly evaluate cardiac function, and determine the presence of hemorrhage in the chest or abdomen. Additionally, ultrasound assessment of IVC collapsibility is proving to be a reliable method to monitor intravascular volume status in mechanically ventilated and non-ventilated patients. Ultrasound has been widely accepted and incorporated into critical care practice as a guide for ensuring accuracy in procedures such as thoracentesis and paracentesis, is being used to assist with thoracostomy tube placement, and is arguably a standard of care in central venous catheter insertion. The management and resuscitation of the critically ill or injured patient remains a complex issue in the ICU, despite all of the methods of monitoring currently available. Ultrasound, refined for use in the ICU, provides information using validated techniques that are available at bedside, non-invasively, with minimal risk. The ability to perform and interpret ultrasound and echocardiographic studies lie well within a surgeon's skill set. Realizing that the physiologic questions in the ICU are complex, ultrasound provides meaningful impact for the clinician interpreting the test and answering the medical question at hand. Through even a gross estimation of cardiac function and fluid status, valuable information can be obtained to guide a complex resuscitation and arrive at clinical decisions earlier compared to the application of other hemodynamic monitoring modalities. For these reasons, ultrasonography augments the physical exam and allows for a better evaluation of the critically ill or injured patient. We are happy to present a selection of our ultrasonography application and experience in our ICU. TEE allows for surgeons to get to resuscitation answers quickly and have immediate access to hemodynamic assessment and treatment effects. TEE has long been the gold standard to assess for patient cardiac function, but its availability in the past has been limited to non-surgical specialists and required expensive, complex equipment to ensure adequate image resolution and capture. With the newly developed miniaturized disposable transesophageal echocardiography probes, hemodynamic monitoring for complex resuscitations can be achieved quickly, continuously, and easily, with the probe being able to be left indwelling for up to 72 hours. The views obtainable include the transgastric view to assess for preload and contractility, the mid-esophageal view to inspect biventricular size and function, and the superior vena cava view to assess for volume status and fluid responsiveness. A 71-year-old female status post open abdominal aortic aneurysm repair was transferred to the ICU for postoperative care. Despite intraoperative reports of aggressive volume replacement, the patient arrived in the ICU hypotensive, tachycardic, with low urine output and on a significant amount of vasopressors for hemodynamic support. A transesophageal echocardiography probe was immediately placed and assessment of her volume status was performed. In the superior vena cava view, the patient was noted to be volume depleted through the identification of a small diameter SVC. Her mid-esophageal view revealed hyperdynamic cardiac wall motion and collapsible ventricles. Aggressive volume replacement was initiated. 3 hours after resuscitation efforts, repeat TEE was performed to assess for effect. The patient's SVC view revealed an increase in its diameter. The patient's mid-esophageal view demonstrated slowing of her cardiac wall motion and less collapsibility. The patient went on to wean from vasopressor support, maintained normal hemodynamics, and extubated a few days later.